Welcome to Advances in HER2-positive and HER2-low breast cancer. The objectives of this talk are to summarize recent clinical advances in the medical management of patients with HER2-positive breast cancer and to describe the science and emerging evidence around the diagnosis and treatment of HER2-low breast cancer. We will begin the course talking about HER2-low breast cancer, followed by heterogeneity in HER2 expression, new technologies to detect HER2 status, HER2 somatic mutations in breast cancer, and HER2 clinical trials. So what is HER2-low breast cancer? As was previously mentioned, adjuvant Herceptin, or trastuzumab, reduces invasive breast cancer recurrence and risk of death in patients with HER2-positive tumors. A subset of patients in the original trastuzumab adjuvant trials who originally tested HER2-positive were deemed to be HER2-negative by centralized testing. Though negative, they still appeared to possibly benefit from trastuzumab. This finding helped initiate a discussion of HER2-low breast cancers. While no formal definition of HER2-low breast carcinoma exists, trials suggest that HER2-low breast cancers are those that are 1+ or 2+ by immunohistochemistry and lack HER2 amplification. When applying this definition across the board, roughly 55% of breast cancers would be categorized as HER2-low. This classification represents a spectrum of carcinomas with different degrees of HER2 expression. Studies have shown that these carcinomas have a poorer prognosis compared to HER2-negative breast cancers. Typically, these cancers are ER-positive and are usually the luminal B molecular subgroup by gene expression analysis. They tend to have a higher histologic grade and a higher proliferation rate when compared to ER-positive, HER2-negative tumors. Another caveat with HER2 testing is HER2 heterogeneity. The 2018 ASCO-CAP update addressed HER2 heterogeneity identified by in situ hybridization. This is contained in the supplemental data and is similar to that which was described in the 2013 ASCO-CAP guidelines. It reads as follows: any aggregate population of amplified cells comprising greater than 10% of the total tumor cell population on the slide must be separately counted. The number of CEP17 and HER2 signals should be counted in a minimum of 20 non-overlapping and contiguous invasive cancer cell nuclei in at least 2 tumor areas of each population of tumor cells, both unamplified and amplified areas. The HER2 CEP17 ratio should then be calculated for each population of cells individually, including the average HER2 signals per cell and the ratio of HER2 signals to CEP17 signals. Cases containing amplified and non-amplified areas using this definition should be reported as positive for HER2. The percentage of the total tumor population with amplification should also be reported. So what do we know about tumors with heterogeneity for HER2? These tumors are associated with a larger size, a higher histologic grade, and a greater frequency of lymph node metastasis. Patients with HER2 heterogeneity seem to be less responsive to anti-HER2 targeted therapy. Trials have shown a lower achievement of pathologic complete response following neoadjuvant therapy with trastuzumab-containing regimens. Here are photographs of a tumor showing HER2 heterogeneity using immunohistochemistry. In the picture on the left, you see an invasive carcinoma in which some cells show little to no staining, while others show dark circumferential membrane staining that would be considered 3+ if the appropriate percentage were positive. The picture on the right shows a similar population of cells at a higher magnification. Note the complete circumferential membrane staining of the positive tumor cells, with adjacent tumor cells being completely negative. Here's an example of CISH showing HER2 heterogeneity. You can see there is a population of cells toward the center of the picture, which show brown signals indicating HER2 amplification, while surrounding cell nuclei lack this finding. Here is an example of a case presentation of a patient whose tumor displayed HER2 heterogeneity by immunohistochemistry. The tumor on the left side of the photograph shows a negative or 1+ score, whereas the tumor on the right side of the picture clearly shows 3+ positive complete and circumferential membrane staining, these existing within the same tumor. This is the same case using CISH. This is the area of HER2 3+ immunohistochemistry staining. You can see here that CISH shows amplification of the HER2 gene, indicated by black or brown dots. In contrast, within the same tumor, this is the area corresponding to the 1+ immunohistochemistry score for HER2. You can see an absence here of HER2 amplification. The pictures on the left show an H&E of the primary tumor on top and an image of CISH performed for HER2 on the bottom, which does not show HER2 amplification. The image all the way on the right shows a metastatic focus from this tumor, an H&E on the top, and CISH on the bottom, which clearly shows HER2 amplification. Now we'll talk about some alternative methods for HER2 testing. The commonly used Oncotype DX platform has shown conflicting reports in the literature for HER2 reporting. In one study, there was a 97% concordance rate between FISH and RT-PCR, with 12% and 11% of patients being shown to be HER2 positive by PCR and FISH, respectively. Another trial showed a high false negative rate by Oncotype DX, with 99% of negative cases being confirmed as negative by PCR, 28% of positive tumors testing as positive. 33% of these initially positive cases were found to be equivocal using PCR, and 39% were found to be negative. Another study indicated a 99.2% concordance rate for HER2 testing. In this trial, there were 3 HER2 positive cases by FISH, 2 of which were found to be negative and 1 equivocal when using Oncotype DX. A high concordance rate between PCR versus IHC and FISH. In this study by Perez, there was a 95% concordance for PCR versus immunohistochemistry, 91% for PCR versus FISH, and 94% for IHC versus FISH. Another study indicated that HER2 equivocal cases may be positive by FISH, but negative by Oncotype DX. In their study, 13 HER2 IHC equivocal cases, there were 3 HER2-positive cases by FISH, whereas all were found to be negative by Oncotype DX. In this study by Neely, 5 of 568 cancer cases were HER2-positive by IHC and FISH, whereas only 1 was positive by Oncotype DX. The data from at least some studies suggest that the discordance in HER2-positive cases between IHC and FISH versus Oncotype DX is high. Thus, the preferential use of Oncotype DX results over IHC and FISH is discouraged. There is much promise in next-generation sequencing, though it is not routinely used to determine HER2 status. Overexpression of the HER2 protein occurs through HER2 gene amplification or rarely through other transcriptional or translational mechanisms. With the advancement of next-generation sequencing, the capability to concurrently derive copy number alteration data from the same assays used to detect sequence alterations may provide a cost-effective and tissue-efficient alternative to current single-gene assessment methods. HER2 amplification status can be reliably determined by hybridization capture-based NGS methods, allowing efficient concurrent testing for other potentially actionable genomic alterations. In this study by Ross et al., the Memorial Sloan Kettering IMPACT hybrid capture-based NGS assay was used on manually macro-dissected unstained sections of breast cancer, showing a 98.1% concordance with combined immunohistochemistry and FISH results. When discrepancies occurred, they were in the context of low tumor content and HER2 heterogeneity. A study by Lin et al. Utilized amplicon-based NGS to detect HER2 copy number variation. The copy number detected by next-generation sequencing correlated with the average HER2 copy number and the HER2 CEP17 ratio. There was a 95% sensitivity, 99% specificity, and 97% concordance when using optimized cutoff values determined by using 131 HER2 non-amplified breast cancers. HER2 somatic mutations, which we'll talk more about in a moment, have been shown to be an alternative mechanism to activation of HER2 in breast cancers. And the majority of HER2 somatic mutations in breast cancer are activating mutations that probably drive tumorigenesis. The frequency of reported HER2 mutations in breast cancer are relatively low, ranging from 2.4 to 4.2%. Breast cancers with HER2 mutations may not be detectable by immunohistochemistry or FISH, but metastatic breast cancers driven by mutant HER2 may respond to anti-HER2 targeted therapies. We know that different genomic testing platforms have different cutoffs. So if no HER2 amplification is detected by NGS, is it possible that a lower level amplification or overexpression exists? So now we'll discuss somatic mutations in HER2 in breast cancer. Recent next-generation sequencing studies have shown that breast carcinomas can harbor HER2 activating mutations. Most HER2 mutations do not result in HER2 amplification or overexpression. HER2 somatic mutations are less prevalent than HER2 amplification, as they occur in about 2.7% of breast cancer patients, as we described earlier. Among breast cancers harboring HER2 alterations, the co-occurrence of gene amplification with mutations has been identified in less than 1% of cases. HER2 mutations have been reported in both the tyrosine kinase and extracellular domains. The majority of HER2 mutations affect exons coding for the tyrosine kinase domain and less commonly involve the extracellular domain. In a large series of 5,605 cases of advanced or metastatic breast cancer reported by Ross et al., 90% of HER2 mutations occurred in the kinase domain, and only 10% in the extracellular domain. Missense mutations have been the most common alterations in the extracellular domain, affecting the furin-like cysteine-rich domain that is crucial for receptor dimerization. Tumors harboring HER2 mutations commonly show co-mutations PIK3CA and CDH1. A higher frequency of lobular histology, especially the pleomorphic type, has been reported due to the common co-mutation of CDH1. Some tumors with HER2 mutations have stronger tyrosine kinase activity than wild-type HER2, indicating the activation of HER2 without HER2 amplification or overexpression. Different mutations may be associated with differential response or resistance to different therapies. Some of the mutations have been reported to confer sensitivity to the tyrosine kinase inhibitors, neratinib and lapatinib, while others have been reported to be associated with resistance to hormonal therapy and aromatase inhibitors. There is obviously a need to expand HER2-targeted therapy. We know that trastuzumab therapy in combination with chemotherapy is effective in treating 40 to 60% of HER2-positive breast cancer patients. We know that there is disease relapse reported in 15 to 20% of patients, and pharmacological resistance to trastuzumab and other HER2-directed therapies obviously adversely affects treatment outcomes. Ways to circumvent these issues forms the basis of many ongoing clinical trials. The trastuzumab and tansine for residual invasive HER2-positive breast cancer, or CATHERINE trial, evaluated HER2-positive primary breast cancer patients with residual invasive carcinoma in the breast or axillary lymph nodes after neoadjuvant chemotherapy with HER2-targeted therapy, using a taxane and trastuzumab. Patients with residual disease were randomized to receive adotrastuzumab and tansine or trastuzumab alone. This drug, or TDM1, is an antibody-drug conjugate consisting of the humanized monoclonal antibody, trastuzumab, covalently linked to the cytotoxic agent DM1. This molecule undergoes receptor-mediated internalization into HER2-expressing cells, where the conjugate is catabolized in lysosomes with DM1 containing catabolites released to bind tubulin and cause mitotic arrest and cell death. The primary endpoint of the CATHERINE trial was disease-free survival. This was defined as freedom from ipsilateral invasive breast cancer recurrence, ipsilateral locoregional invasive breast cancer recurrence, contralateral invasive breast cancer, distant recurrence, or death from any cause. At the interim analysis, with 743 patients in both the TDM1 group and the trastuzumab group, invasive disease or death had occurred in 12.2% of patients in the TDM1 group and in 22.2% of patients in the trastuzumab group. The percentage of patients who were free of invasive disease at 3 years was 88.3% in the TDM1 group and 77% in the trastuzumab group. This was found to be highly significant. In patients with residual invasive carcinoma after neoadjuvant therapy, the risk of recurrence of invasive breast cancer or death was 50% lower with adjuvant TDM1 than with trastuzumab alone. There is a relationship between the body's immune system and cancer. Post-anti-tumor immune responses are predominantly mediated through CD8-positive cytotoxic T lymphocytes. These cells recognize tumor-associated antigens and provide immune protection through the secretion of interferon gamma, tumor necrosis factor alpha, and other cytotoxins. Additional anti-oncogenic effects of the immune system occur through the activation of macrophages, natural killer cells, and CD4-positive helper T cells. Unfortunately, cancer is able to evade the host immune system through tumor-mediated immune escape mechanisms by suppressing cytotoxic T lymphocytes. They do this by downregulating antigen processing and presentation, leading to losses of major histocompatibility complex class I protein expression, low human leukocyte antigen class I expression, and defects in T cell receptor signaling. avoiding destruction through the recruitment of immunosuppressive elements such as regulatory T cells, myeloid-derived suppressor cells, and tumor-associated macrophages. By increasing production of immunosuppressive cytokines within the tumor microenvironment, such as TGF-beta and interleukin-10 to escape immune surveillance, and by utilizing immune checkpoints to suppress the cellular immune response and promote immune tolerance. So how can we utilize the host immune system against cancer? Immunotherapy enhances tumor recognition by the immune system and augments cytotoxic T lymphocyte activity. Breast cancer has an immunogenic nature, as highlighted by work on tumor-infiltrating lymphocytes. We know that higher levels of tumor-infiltrating lymphocytes are present in patients with HER2-positive and triple-negative breast cancers than in hormone receptor-positive cancers. Analysis of tumor-infiltrating lymphocytes in a large cohort of breast cancer patients indicated that the presence of CD8-positive T cells is associated with a lower risk of mortality in ER-negative and ER-positive HER2-positive tumors. In HER2-positive breast cancer, higher levels of tumor-infiltrating lymphocytes are associated with good prognosis in terms of improved survival and response to therapy, as well as higher rates of pathologic complete response. Programmed cell death 1 and programmed cell death 1 ligand blockade are also being examined in breast cancer. PD-1 is expressed on activated T cells. It binds to its ligands, PD-L1 and PD-L2, leading to decreased cytokine production and cytolytic activity of T cells. PD-L1 has a wide tissue distribution and contributes to the inhibitory signals that attenuate T cell activation, leading to immune tolerance. Immunotherapeutic agents blocking PD-1 and PD-L1 are used to enhance the anti-tumor immune response. PD-L1 expression has been associated with unfavorable clinical pathologic features, such as large tumor size, high tumor grade, hormone receptor negativity, and HER2 positivity. Pembrolizumab and nivolumab are monoclonal antibodies directed against PD-1. Additionally, there are multiple drugs targeting PD-L1. Clinical trials investigating these immune checkpoint inhibitors are in their early days, with phase 1 and 2 trials looking at patients with metastatic or advanced disease in patients that have typically received multiple lines of prior therapy. Next, we'll talk about the Panacea study. This is a phase 2 study utilizing pembrolizumab in combination with trastuzumab in HER2-positive metastatic breast cancer patients who progressed while on trastuzumab treatment. Patients with PD-L1 positive and PD-L1 negative tumors were both enrolled in parallel cohorts and received the flat dose of pembrolizumab plus standard trastuzumab. The primary endpoint of this phase 2 study was the proportion of PD-L1 positive patients achieving an objective response. 52 patients were enrolled, 40 with PD-L1 positive tumors and 12 with negative tumors. The median follow-up was 13.6 months for patients with PD-L1 positive tumors and 12.2 months for patients with PD-L1 negative tumors. 15% of the 40 PD-L1 positive patients achieved an objective response, with no objective responders among the PD-L1 negative patients. Here is a list of clinical trials of PD-1 and PD-L1 in HER2-positive breast cancer. There are also clinical trials ongoing around vaccines in breast cancer. Therapeutic cancer vaccines are used to treat tumors by enhancing the anti-tumor immune response. Cancer vaccine strategies utilize specific tumor antigen-derived peptides, proteins, DNA, RNA, and dendritic cell lysates. They induce immunity by stimulating immune regulators such as antibodies, helper T cells, and cytotoxic T lymphocytes that should establish immunological memory. Nelipepimut S, or E75, is a 9-amino acid peptide from the extracellular domain of HER2. It binds to the HLA-A2 and A3 molecules on antigen-presenting cells and stimulates cytotoxic T lymphocytes to recognize and lyse HER2 overexpressing cells. Nuvax is a vaccine composed of nelipepimut S and the hematopoietic growth factor, granulocyte macrophage colony stimulating factor G. Granulocyte macrophage colony stimulating factor induces proliferation, maturation, and migration of dendritic cells to enhance the nelipepimut S specific immunity through increasing antigen presentation to cytotoxic T lymphocytes. E75 vaccination has been shown to decrease circulating levels of Tregs in the majority of vaccinated breast cancer patients. Immunogenic potential of nelipepimut S was shown in breast cancer patients irrespective of the level of HER2 tumor expression. The present trial was a multi-center, multinational, prospective, randomized, double-blind, controlled phase 3 trial looking at the efficacy and safety of Nuvax administered with adjuvant leukine. The trial enrolled breast cancer patients who had lymph node positive disease and low to intermediate expression of HER2. For this trial, disease-free survival will be compared between 758 vaccinated patients and control patients. Preclinical findings have suggested that trastuzumab enhanced breast cancer cell killing by HER2-new peptide-stimulated cytotoxic T lymphocytes are possible. There are 2 clinical trials underway to assess the combination of nelipepimut S with trastuzumab. This is a phase 2 multi-center prospective randomized single-blind placebo-controlled trial of trastuzumab and nelipepimut S along with GM-CSF versus trastuzumab and GM-CSF treatment alone. One study will evaluate high-risk HER2-positive patients with high HER2 expression levels. The second will evaluate lymph node-positive patients with low to intermediate HER2 expression. The primary endpoint is to compare disease-free survival between treatment groups. The DESTINY trial looks at trastuzumab deruxtecan versus the investigator's choice for HER2-low breast cancer that has spread or cannot be surgically removed. This is a phase 3 multi-center randomized open-label active control trial of DS-8201A, which is an anti-HER2 antibody drug conjugate, versus the treatment of the physician's choice for HER2-low unresectable and/or metastatic breast cancer subjects. This trial is enrolling 540 patients. The primary endpoint is progression-free survival by blinded independent central review. Antibody-drug conjugates, or ADCs, are monoclonal antibodies covalently bound to cytotoxic agents and are designed to target and deliver chemotherapy inside of cancer cells. This reduces systemic exposure to the cytotoxic agent. ADCs bind to cell surface antigens. The complex is then internalized, killing the antigen-expressing cells. The surrounding cells, though they may not express the receptor, are also killed as the cytotoxic drug is released into the extracellular space, which is the so-called bystander killing or bystander effect. So how do we get to the DESTINY trial? DS-8201 is a compound of trastuzumab attached to a novel topoisomerase I inhibitor that has been shown to have a potent bystander effect. The released payload is membrane permeable, so it may exhibit a cytotoxic effect on neighboring tumor cells in close proximity to the targeted cell, regardless of the neighboring cell's HER2 expression levels. A phase 1 study of DS-8201 reported data on pre-treated HER2-low metastatic breast cancer patients, demonstrating an overall response rate by independent central review of 37%, with a median duration of response of 10.4 months in 54 extensively pre-treated patients.